It being my honor to be able to introduce Dr. Mahavir Agarwal, who's going to give us the Sarah Ann Campbell Memorial Lecture, this year titled Prevention and Early Intervention for Metabolic Disorders in Individuals Experiencing SPMI. Dr. Agarwal is an associate professor in the Department of Psychiatry at the University of Toronto and a clinician-scientist in the Schizophrenia Division at the Centre for Addiction and Mental Health, otherwise known as CAMH. He's the medical head for clinical research in the Schizophrenia Division and leads the Metabolic Clinic and the Clozapine Clinic at CAMH. And I can say personally, as someone who got to train in the Metabolic Clinic, he's doing really cool and innovative stuff. And I hope that more people are going to emulate the kind of work that he's doing across the country and internationally. His research interest lies in understanding the mechanisms underlying metabolic and cognitive dysfunction in folks experiencing SPMI, with a focus on insulin signaling in the brain and trying to discover new treatments for these abnormalities. He's won multiple international research awards, has over 85 publications, and his research program has been funded by generous support from several federal and provincial agencies, including CIHR, PSI Foundation, and the University of Toronto. So welcome, Dr. Agarwal, and I really look forward to your talk.
Thank you, Dr. Levitt, for the kind introduction and for having me here. Let me see if I can share my screen. All right. Can you see the slides and the right version of the slides? Excellent. So thank you again. So today we are going to discuss a topic that is quite near and dear to my heart, and something that we spend a lot of time doing in our clinical role in the metabolic clinic at CAMH, which is to prevent, ideally, and if not prevent, intervene early when it comes to metabolic disorders in individuals experiencing SPMI. And so through this talk, we'll try to understand why this is important, how we could go about doing this, and how we have been doing this, and sort of come upon a shared understanding of what the next steps could be. So to begin with my disclosures, I have worked with these two companies in the past to promote largely cognitive and metabolic health. But so today, the objectives of the talk are, first, we will try and understand the importance of metabolic health in patients with schizophrenia and related mental illnesses. We'll understand some of the new clinical research that helps us treat these better. And then towards the end, we'll discuss how some of the practices here at CAMH and elsewhere are helping make, hopefully, better, improve this outcome. The other thing is that when I get excited, I tend to speak very quickly, and this is something that interests me a lot. So if I'm going too quickly, please someone let me know, and I'll try and slow down. Okay, let's move on with the first objective. So let's start with the why this is important. So I start with these two pictures. The person on the left, of course, is Albert Einstein. We all have heard of him. The person on the left, on the right, is his second son, Edward Einstein. You may or may not know that Edward Einstein wanted to be a psychiatrist and was in medical school in his second year when he developed schizophrenia, and then was treated with the treatments of that time. Not very different from the treatments now in terms of antipsychotics and ECTs, etc. And then and he died of a stroke at the age of 55. Albert Einstein, like we may know, lived till the age of 76. And so this sort of illustrates this 20-year mortality gap, which has now become accepted fact in our field of work. Our patients tend to live much less compared to the general population. Our patients tend to also have significantly higher rates of obesity and overweight, and much of this excess morbidity comes from cardiovascular health. In the general population, rates of cardiovascular illnesses are on the decrease. However, this benefit is not being transferred to patients with severe mental illness. And so this gap between the non-mentally ill and the severely mentally ill in terms of cardiovascular health is actually increasing with time currently. And none of this is new. Remarks as early as the 17th century and 18th century have noted this overlap between diabetes on one hand and mental illness on the other. And More recently, we have developed a more organized and sort of more sophisticated understanding of this overlap, where we understand that with illnesses such as major depressive disorder, diabetes, they are reciprocal in terms of the susceptibility they confer. And for bipolar disorder and schizophrenia spectrum disorders, they might be independent risk factors. And so this is more complicated than we had earlier imagined. And this relationship, therefore, between severe and persistent mental illness and metabolic disorders such as diabetes, obesity, and metabolic syndrome is not a straight line, and are multifactorial. So there are, of course, lifestyle factors. Our patients, for various reasons, are more likely to have less access to good food, good lifestyle, good dietary choices, and so on. But there are also system factors. We were discussing very briefly in the breakout room that systems don't work as efficiently and as nicely as they could or would or should. There's so many barriers that are set up for our patients to access quality care. But then there's illness biology as well. Inherently, multi-level omic research has shown, so at the genetic level, at the protein level, that there is a significant overlap between schizophrenia, spectrum illnesses, and metabolic dysfunction. And then last but not the least, our treatments add to this. Again, please don't get me wrong. I'm not saying that patients with mental illness should not be on treatments. These treatments are the cornerstone of our management. However, it is also without doubt that they add to the metabolic dysfunction that our patients experience. And this case is the clearest in the case of antipsychotics. And so if we focus on schizophrenia spectrum disorders, the advances that we have noticed in the last 50 years almost is that we have had a second generation antipsychotics come up, and they have for the large part replaced or displaced the first generation antipsychotics from the market. But what we have done is we have traded side effects. So we have, of course, reduced burden of motor side effects, but we have now a new group of side effects, which are the metabolic side effects. So such as weight gain, insulin resistance, and dyslipidemia. And while this issue is clearest when it comes to antipsychotics, they are by no means alone in terms of conferring this risk. This is a table that shows the various psychotropic medications we use, and drugs like mirtazapine and paroxetine and amitriptyline among antidepressants, valproic acid and among mood stabilizers, and of course the clozapine, the olanzapine, the risperidone, when it comes to antipsychotics, confer significant metabolic risk. And then even this gradation between agents that we have classically been taught and understood is not always true. So when it comes to, so these are data out of a landmark study published in 2009. When they looked at all patients they had recruited, they saw this difference between, an olanzapine and a risperidone and an aripiprazole. Their weight gain potential was quite different. But when you look at only antipsychotic naive patients, this difference gets collapsed significantly. So when it comes to young, first episode, antipsychotic naive individuals, almost all of our drugs can cause significant weight gain. And so we cannot say that, okay, let me start this person on, let's say, a drug like aripiprazole, and I don't have to worry about metabolic side effects. That does not happen. In the young, the vulnerable individual who is not exposed to antipsychotics, even aripiprazole can lead to significant weight gain. We have had people who have doubled their weight on aripiprazole. So it is by no means a metabolically safe drug. It's just that the propensity is a bit low. However, monitoring and early intervention still plays a role. And if you look at some of the reasons why this happens, why this early weight gain happens, antipsychotics cause a massive alteration in peripheral and central hormonal dynamics. And this includes ghrelins, insulin, neuropeptide Y, etc. And there are more and more data available in our lab and elsewhere in the world that this starts from the very first dose. And this leads to a severe and persistent increase in appetite. Now compare this, for example, with extrapyramidal symptoms. Extrapyramidal symptoms also set in quite early. We know them well, and we know how to treat them well. We don't wait as clinicians to treat extrapyramidal symptoms such as rigidity or tremors. We have drugs, and we do not hesitate about prescribing those drugs. However, when it comes to metabolic dysfunction, hesitation sets in. We don't treat it at the same level. We sometimes feel underqualified, or sometimes we feel that this is out of the scope of our work. it's also that this is a long-term problem, and so we wonder whether we should intervene later versus now. So, and then we think of maybe behavioral strategies would be helpful. Maybe we can ask them to eat less or exercise more. However, this is neurochemically driven. It's not easy to exercise away antipsychotics. You can't diet away or exercise away in most situations the massive changes that drugs like antipsychotics cause. And therefore, behavioral strategies overall, I mean, they should always be prescribed, but we have to recognize that they are of limited use and they need supplementation with all the other tools that we have at our disposal. And in that context, early intervention helps. And then in the later part of the talk, I'll show you some of the evidence that supports earlier intervention, the utility of it and the safety of it. And then this is another thing I wanted to highlight. This is again a massive study out of Denmark, from our Danish colleagues, and they have access to these population level data, and they published this amazing work that showed that people with severe illnesses, severe mental illnesses such as schizophrenia, have at baseline a 3 times higher risk of developing diabetes. And then if they were started on antipsychotics, that risk increases by a further 3-fold. It does not seem to matter what antipsychotic they are on. The tables, the graph that you see, the differences between individual agents was not significant. The fact that was significant was any antipsychotic increases the risk of diabetes by about 3 times. So again, if you go back to the question of aripiprazole being a metabolically safe drug, sure, it may have less weight gain potential in the short term, but in the long run, it seems that all antipsychotics increase the risk of diabetes. And again, that tells us that we have to be mindful from the get-go. And it does not stop at cardiovascular health. This is a much wider problem because it has a direct impact on the motivation to take medications. Stopping metabolic side effects are one of the most important and the most common reasons why people stop taking their medications. And you can only imagine if somebody's not taking the medications they're prescribed, they're less likely to do as well in terms of their symptom control. And this has cascading effects on overall quality of life and social care costs. And then we are realizing now in a more concrete manner that this has impact on cognition. And so we already are in a space where we don't have good answers for cognition, for cognitive symptoms and severe and persistent mental illness. We really don't have any drug that works there. But we are dealing with metabolic dysfunction that actually worsens cognition. And so the least we could do is not add to the problem. And yet we are not proactive about that. And this is the slide that sort of is in one slide, the reason why I do this work. So these are data out of 34 community health facilities in the US. These data describe the experience of young people. The average age is about 20 years, and they have been on antipsychotics for less than 6 months. So the average antipsychotic exposure is about 3 months. And even now, the super young, super sort of freshly treated population has rates of dyslipidemia at above 55%. More than 15% have pre-diabetes, and around that number have metabolic syndrome already. So even within 6 months, they have this much metabolic dysfunction. So those are the dark bars. If you look at the light bars, that is the rate of interventions that we have offered these individuals, and across the board, it's 0. We as a field do not do a good job in treating the most common side effect of our medications. And so to summarize this part of the talk, the cornerstone of our management strategy can be effective, but they cause significant metabolic side effects. And these side effects add to the burden of the illness. And therefore, we need newer strategies or targets to handle this. And so what can we do? Oh, sorry. Yeah, there we go. Let's focus on the second bit now, how clinical research addresses this. And so the reason we have to do this research separately outside of so-called normal population is because the causes of metabolic comorbidity might be different in our population compared to the general population, and treatments may not work the same way. A classic example would be, metformin. Metformin is not known as a weight loss drug in the general population. However, it works very well in our population. Some of the drugs that have been approved for weight loss in the general population conversely don't seem to do so well when it comes to our patients, and therefore we need to look at them in a more systematic manner. And there is in general a paucity of studies looking at interventions outside of weight gain. And most of these studies have been done in context of antipsychotics. So then as a clinician, if we are treating metabolic dysfunction, these are the 4 strategies that are traditionally available to us. We could reduce the dose, we could switch the agent, we could add non-pharmacological interventions, and then we could look at pharmacological interventions. So let's go through them one by one and see how effective they are. So when it comes to lowering antipsychotic dose, in general, there's a paucity of data. However, and there is less evidence that metabolic dysfunction is dose related. What we do know is that lowering the dose may not result in decrease of metabolic dysfunction, and in fact, it may put people at an increased risk for relapse. So if you look at good clinical practice, you want your patient to be at the lowest efficacious dose. If you have established that lowest dose and you have symptom control, the benefit of going down from that dose is just not there. It will not improve metabolic health. It puts them at risk, right? So it's not a good strategy, just dose reduction from the point of view of metabolic side effects alone. I mean, again, the message is not that you should not reduce dose. If somebody is more on doses higher than you think they should be from a general clinical point of view or symptom control point of view, then yes, by all means, but not only for metabolic dysfunction. When we look at switching strategies, there are some data available now, and it appears that if you switch from a high liability agent, again, these are more stable patients who have had the illness for a while. And so if you switch from olanzapine to a drug like aripiprazole or quetiapine, it might be of benefit. A more recent clinical trial showed that if somebody is on a 2nd generation antipsychotic, switching to a drug like aripiprazole or metformin can be equally beneficial. However, we have to recognize that switching itself is inherently risky in somebody who is doing well, and that in some cases that may not be an option. So if somebody is already on aripiprazole or quetiapine and is gaining weight, what do you do? Or if somebody is on clozapine, what do you do? Switching is not always available. However, if this is an option and the patient and the caregiver can be in a shared decision setting and embark on this can be a strategy where appropriate. If you look at behavioral interventions, the evidence is a bit mixed. Overall, they do seem to work. They offer a modest weight loss of about 3 kilograms. So these include strategies such as dieting, exercising, CBT, all of that is captured together. They can help prevent weight gain as well as treat. However, the problem is sustainability and the cost, because a lot of these programs are highly monitored. A lot of time and resource goes into setting up these programs and making sure that our patients and participants are able to attend. In the long run, the efficacy and the sort of the cost effectiveness of this becomes problematic. And this is what was assessed in a very large study, the largest study that has come out in this space, called Stepwise, where they had people who were doing a group-based structured lifestyle education program for 12 months, which was fairly involved, but also sort of sustainable, not so intense that it's not sustainable. And they had about more than 400 patients. However, they did not find any difference in outcomes at the end of the study and concluded by saying that this is neither clinically effective nor cost effective. And so behavioral interventions, therefore, can work in the right setting. However, they need some time and effort and resources to go in to set it up and to keep it going. Then let's go to the pharmacological interventions, and let's speak about metformin first. So this is a Cochrane meta-analysis that should come out sometime next year, where we analyzed all the studies that had assessed metformin for the treatment of weight gain in SMI. And we found that metformin is effective. Overall, the weight loss is, again, quite modest, 3.5 kilograms. But then if you look at the 2 diamonds, I hope you can see my circle, my cursor, the top diamond and the middle diamond here. The top diamond represents what happens when metformin is started early in first episode individuals. And there we see that the effect is more than 5 kilograms, so more than 5 kilogram reduction in weight. However, if we wait too long and start it in people later on, the effect is less than half, 2.22 kilogram. And so these results would indicate to me that the sooner you start metformin, the better it would be. We also published some work showing that when it comes to antipsychotic related dyslipidemia, so antipsychotic-related dyslipidemia is unique in that it is characterized by high triglyceride levels and low HDL levels, and not so much LDL-related dysfunction. And so in that space, metformin actually works very well and has the largest effect size when it comes to treating antipsychotic-induced dyslipidemia. In fact, it's better than the efficacy for statins. And so again, it seems like, a one-drug solution that we could all become very comfortable with because it's safe and it's effective. And then this is a review that was published last year, again, a Cochrane meta-analysis where we looked at prevention. So studies where drugs like metformin were started at the same time as antipsychotics, not waiting for weight gain. And there again, it was found that metformin is effective. It can prevent weight gain by about 4 kilograms, or the treated and untreated groups differed by 4 kilograms. And these were all short-term studies. So within 12 weeks, the difference is about 4 kilograms. If you sort of stretch it longer, it is possible that the benefits might be larger. And so again, metformin, so to summarize what we have seen up until now, metformin is effective as a primary preventative agent. Metformin is effective if you start it early as an early intervention agent. Its efficacy seems to be a bit lower when it started late, but it still works. And then we actually did a study where we looked at people who had already developed prediabetes or diabetes and to try metformin in them. And there we found that metformin does not bring about weight loss. It still is good in terms of reducing insulin resistance and glucose levels, but not weight. And so it appears to, based on these data, that metformin's efficacy in reducing weight sort of goes down with time. The sooner you start, the better it is. Now, none of these studies included, these prevention studies included people on clozapine. And so we wanted to, I combined my hats in the clozapine clinic and the metabolic clinic and tried to answer the question if metformin can prevent clozapine-induced weight gain. So we did a chart review of over 400 patients who had the data available, and we divided them into two groups, people who were on clozapine alone or people who were on clozapine and metformin within 3 months of being started on clozapine. And we compared these two groups over 12 months in terms of their weight and other metabolic parameters. And what we found was striking. Patients who were on metformin along with clozapine did not gain weight in the 1 year, while even though they were on clozapine, they actually lost some weight. Whereas people who were on clozapine alone continued to gain weight as we would expect and were about 4.5 kilograms heavier than people who were on metformin and clozapine. And so that was interesting. But then when you look at their fasting blood glucose and triglyceride levels, there also you see this clear separation. People who were started on metformin when they were started on clozapine actually did better. And then this is the result that was the most striking to me, and the result that made me the happiest, that if people were on clozapine along with metformin, they were 15% more likely to still be on the clozapine at the end of 1 year. Now, this is a major problem with clozapine. We all know this. The clozapine continuation rate is about 50% at 1 month. And here we have an intervention which is easy, safe, and accessible, which can improve this by 15%, while also improving metabolic health, like weight and fasting glucose. And this result was very interesting to me, that you can actually treat metabolic dysfunction. And it proves the point that if you take care of the side effects, people are more likely to take their medications. And so, yeah, and so based on this, we have actually modified our policy, clozapine policy at CAMH, and we now recommend that physicians consider a metformin start when they're starting clozapine as well. I mean, the policy, Canadian obesity guidelines now talk about metformin as an agent for prevention and treatment of antipsychotic-induced weight gain more widely. So I think metformin could be started for everyone who's being started on antipsychotics or where the risk is high, but for clozapine, definitely these data support it. Now, while I like to speak about metformin a lot, the question also becomes, well, how often is metformin effective? Is it effective for everyone? And what do you do if metformin is not effective? And so if you look at our clinical data and some of the clinical trial data that has been published, it appears that if you start sort of reasonably late, so you're treating the average person who has had schizophrenia for, let's say, 5 years or so. So this is not early intervention. This is not prevention. The efficacy rate defined as more than 5% weight loss hovers around 20%. So 1 in 4 to 1 in 5 patients actually respond to metformin, which leaves this huge gap of people who have antipsychotic-induced metabolic dysfunction, or metabolic dysfunction as a part of SPMI, but for whom treatments, there are no other treatments. I mean, metformin does not work. And so in those cases, there are a couple of other options. So topiramate can be a good option. The higher dose of 200 milligrams seems to work a bit better compared to the lower dose. But then again, topiramate comes with its own side effects, such as numbing and tingling sensation, and then some cognitive slowing. And so that needs to be discussed on an individual basis. But when started right and when done right, it can be quite effective. And then, of course, the drugs which are currently quite hot, they're in the media all the time, the GLP-1 receptor agonists. And so these data are analysis of before semaglutide came to the market. And there, this analysis showed that they are also effective in reducing weight gain. So outside of metformin, there's the option of topiramate and GLP-1 receptor agonists. And currently, we are conducting a trial to see if semaglutide is effective in people who have not responded to metformin. So Dr. Margaret Hahn and I co-lead this trial. This is out of CAMH, funded by CIHR, and we are hoping that the results of this study can guide treatment decisions going forward. While we are waiting for these results, we also published a case series of 12 individuals who were started on semaglutide after they stopped responding to metformin. So this is as a part of regular clinical care. And we were it was exciting to see that individuals lost an average of 8 kilograms in about 12 months, even though they had stopped responding to metformin earlier. So semaglutide does seem to work. In our population, the very early evidence seems to suggest that, and there were no major side effects. Most people were able to continue the medication. Most people also continued to be on the metformin, which they were on earlier. So, and this has led to some excitement, so much so that our work was covered by New York Times and Newsweek in the recent past, where they wanted to speak about how important access to semaglutide is in SPMI populations. And I think this is catching on. People are recognizing that it's a very vulnerable population that needs all the help that we can provide it. And so all the agents, all the resources that we can make available and come to bear on this problem, that would be quite helpful. But the other population that we work with, which again fits into this SPMI mold, is adults with intellectual and developmental delay. And so there, oftentimes antipsychotics have started to either tackle aggression or behavioral problems from quite early on. And the rates of dysfunction, metabolic dysfunction and weight gain are often higher than what we see in schizophrenia spectrum disorders. And we started this clinic, a subclinic in the metabolic clinic, looking at these individuals. And we didn't know how effective our drugs would be. And we were quite surprised to find that metformin was actually 3 times more effective in individuals with intellectual and developmental delay than it was in the schizophrenia population. And we have no idea why this is the case. We actually thought that there would be more difficulty in implementing lifestyle and dietary changes, and that continues to be the case. We have difficulty, but they just seem to respond to this drug better. And again, because we didn't know why this is happening, we designed a trial and were fortunate to receive some funding to be able to do that. So we currently have a trial going on where we are looking at the effect of metformin. I'm sorry for the busy slide. It basically says that we are going to randomize people to metformin or placebo for 24 weeks and then continue metformin for everyone after that to see if this drug works, and then to study why this drug works. So we'll do a bunch of blood assessments and MRI assessments, including molecular analysis, to see what are the predictors of metformin-induced weight loss in these patients and how it differs from patients with schizophrenia. All right, so to summarize this part of the talk, metformin is effective in both preventing and treating antipsychotic-induced associated metabolic dysfunction. I take the case of antipsychotic because that is the best studied. However, at the metabolic clinic, for example, we don't really discriminate between the type of psychotropic. Our strategies are largely the same. Overall, metformin seems to work better if it's started earlier. The other options include topiramate. Its use is supported by evidence. There are studies accumulating that support its role in prevention of metabolic dysfunction as well. And then, of course, the newer drugs are exciting possibilities. I would caution that we just don't have the data to be able to confidently say whether and how they should fit into our program just yet. However, it's exciting. It's exciting to be at a time where we finally may have agents that have significant weight loss properties. Some of the newer agents that are likely to hit the market cause as much weight loss as bariatric surgery. We have never had those opportunities before, so it's very nice to be able to see if this would bring about a change. All right, so we are done with the two objectives. Moving on to the third objective, which is to discuss emerging clinical practices in managing metabolic health and preventative and early intervention aspects. So what we have done in the metabolic clinic is we have simplified the monitoring schedule to make it easier to follow and easier to sort of adhere to. And so we request all clinicians to get the detailed metabolic data. So that includes weight, waist circumference, blood pressure, fasting blood work. There we include insulin along with glucose, lipids, and HbA1c at baseline and the first feasible opportunity. And if we are looking at more stable patients, we ask that everything be repeated yearly, especially if everything is normal. However, if you're starting the drugs or they are first episode people or there are any abnormalities, then testing should be done more frequently. Every 3 months is what we recommend. And if there is an abnormality, just monitoring is not enough. So treat it yourself or set up a referral pathway or get somebody involved so they can treat that abnormality. So we can intervene as quickly as possible. And if you're starting clozapine or other drugs such as valproic acid or the first antipsychotic, the monitoring should be 3 monthly. These are the criteria we use before we consider starting a pharmacological intervention. So anybody who's obese, anybody who has BMI more than 27, so overweight and one weight-related comorbidity, or any dysfunction in any of the measures that we are tracking, so fasting glucose or HbA1c. But we also consider these interventions if somebody has gained weight from baseline. So anybody who early weight gain is the best predictor of long-term weight gain. So if you see somebody at baseline and you see them a week or 2 weeks later and they have gained weight, I would encourage you to start intervening quickly because you want to arrest the weight gain before it is coming. Prevention is much better than treatment. And in some cases, we work in close collaboration with the Slate Center at CAMH, which is the early intervention program. And there we have been able to work with individuals who were quite worried about metabolic side effects, where we started metformin and the antipsychotic at the same time. And we were able to head off the metabolic dysfunction, and they were able to go on the antipsychotic and stay on antipsychotic without many of the metabolic problems that would otherwise potentially have happened. So primary prevention is actually feasible. It is safe. I appreciate that it's not always possible, but I think this should be a part of our sort of toolbox. It should be a part of our conversation, and we should be offering it and where available using it. And so this is the kind of flowchart or integrated clinical pathway we use in the metabolic clinic. So the box above describes the same criteria that we saw in the last slide. And we ask if there are any special situations such as residual psychotic symptoms or some binge-related symptoms, in which case we consider topiramate, or if there are mood symptoms, Contrave could be an issue, could be an option. But in a large majority, about 70–80% of our patients, we consider metformin as our first line treatment. And if they respond, that's great. If not, we think of topiramate or go down the path to semaglutide. There are some options here which have not been formally tested in our population, such as semaglutide and dapagliflozin. And so those are some of forward-looking treatments that we are hoping to develop evidence on. So this is basically the algorithm that we have been following at our metabolic clinic. And we have some initial data auditing the efficacy of this clinic. And overall, we find that our approach is effective. The number needed to treat using this combined approach ranges from about 2 to 3 to 5, depending on what intervention the particular patient chooses. So again, think of that. The number needed to treat can be an average of 3 to 4. So every third or fourth person that you see, you can effectively treat metabolic dysfunction with the existing drugs. And if semaglutide becomes available, I'm guessing that the number needed to treat might fall even more. And so the message that I would like to provide is that there are options out there and that we should be using all the tools that we have at our disposal. So to summarize, prevention and early intervention of psychotropic-induced metabolic dysfunction is safe and feasible, and an algorithmic approach to metabolic risk management is efficacious. We have been doing this, and it's not very difficult. these are generally speaking very safe drugs, and I think we should become more comfortable in using them. We should be able to think of metformin with the same ease that we think of benztropine. So to conclude, antipsychotics remain the cornerstone of treatment. There are very high rates of medical comorbidity, including diabetes and obesity in our population. And overall, there are low rates of monitoring and treatment. And therefore, I think prevention and early treatment of psychotropic-induced metabolic dysfunction is feasible and safe. The data show it. And I think it's about time we included that in our clinical practice. I will stop here by thanking the wonderful people that I work with and my collaborators and mentors, Maggie Hahn and Gary Remington, and all my funding sources. Thank you, and I can take any questions that you might have.